Sean, please.
Thank you. Can you hear me okay? Very good. Okay. So for those of you who don't know me, I'm Sean Carey. I'm a rhinologist, skull-based surgeon in Newcastle upon Tyne in the UK. It's a great pleasure to welcome you to this afternoon's session on Dr. My Nose is Blocked, and that covers all manner of ills and evils. So what we're going to do today is just essentially go through a number of clinical cases, and I'm delighted to invite my panel to come up to the front and to take up their place at the table there. And I would have introduced them myself, but I'm not entirely sure who's been invited and who's coming along. So if I can ask the panel to come to the table. Hesham, I think that allows you to step down.
Okay.
Thank you. So we will try to maintain some form of social distancing, which still allows us to make use of the microphones. Well, good afternoon, panel. Are we all sitting comfortably? Let's begin. Can we have the first slide? Yeah, we've got the first slide. So I think the first thing I'll ask us to do is for each of the panelists to introduce themselves to the audience. So, Rob, let's kick off with you.
Rob Kern from Chicago, Illinois.
Okay. Do you want to turn the microphone on there, Marlene? Just.
Hello, can you? I'm Marlene Speth. I'm a resident in Aarau in Switzerland.
I'm Michael Rudenko. I'm allergy consultant and immunology consultant.
Dilyana Vicheva from Plovdiv, Bulgaria.
Hello, welcome, all in Greece. My name is Michael Katotomichelakis, and I'm the professor and head of the University NT department in Alexandroupolis. Thank you.
Great. So we've got an eclectic mix of surgeons and physicians, and we're going to kick off with this first case. So nothing too difficult. This is, well, I say nothing too difficult. This is a 25-year-old patient, presents to secondary care, presents to us as ENT surgeons with a blocked nose, and has had lots of treatment in primary care, but finds that the treatments haven't worked for him, so he's pretty hacked off, can't breathe through either of his nostrils regularly, sometimes gets a bit of breathing on one side, and he sort of pitches up. And I suppose, Michael, this might well be a good case for you to kick off with as an allergologist. We're looking here on the left-hand side at the right nostril, so we've got the septum off to the medially, and then on the right-hand side we've got the left nostril. So this patient pitches up in your clinic. What's your opening gambit?
Allergy test.
Pardon?
Allergy test. Just to find out what. Firstly, to find out what the patient is allergic to.
Okay, well,
the allergy test.
Take us through what sort of history do you take as an allergologist? I'm sure it's much more complex than we do as ENT.
So firstly, we will find out whether it is all the year round or is it seasonal. And then sort of obviously we don't see these pictures when we see the patient. So we will start asking various questions from when did it start, and is it something that they experience at night during the day, or just taking the whole history of these events. And then we'll check other parameters, including whether they have any lower respiratory symptoms, whether there is something happening with their eyes. And and then we sort of will move on to do some tests to find out if this is indeed happening due to the allergic sensitization, or this is something else.
Okay, so you take your history, and he says to you that he's never really had hay fever. He's had a bit of eczema when he was younger. He gets a bit wheezy, but nothing much is looked into with respect to that. He tends to notice the symptoms are worse in the morning than they are later on in the day. Both sides tend to be pretty much involved, though.
And then we need to ask whether he can tolerate non-steroidal anti-inflammatories. So that's the next good question.
Yeah, he's cool with them. He's no problem with non-steroidals.
So we would carry on with the allergy test panel, just checking whether there is anything on the allergy side.
Yeah.
Maybe a bunch of specific AGs if
When you say allergy test, what sort of allergy test do you do?
Mainly respiratory panels, so we'll check the dust mites, all the range of different molds, pollens, cats, dogs, horses, and then we will see whether there is anything to do with that.
And do you do skin tests or do you do RAST?
Depending on the situation, we can do RAST, we can do skin test, we can do both. In some cases, we can do components, we can do ISIAN panel, and see whether that's sort of will come up to any particular guide on leads on this.
Yeah, so your ENT surgeon would send the patient to you. What would you prefer to do? Would you prefer RAST or allergy as your first choice?
Depending, if I see the patient who is on loads of antihistamines, obviously that will be choice is clear RAST. If there will be no antihistamines, I'll do straight away tests in the clinic and we'll give them the answer straight away. So depending what will be the circumstances there.
Okay, yeah. And Mihail, he says to you, he says, I'm fed up with these nasal sprays. I don't want to be using any nasal sprays. I want you to do something about this. How are you going to answer that?
I mean,
Michael and Mihail, sorry.
Yes.
Too many M's on the panel.
So in any case, here we have a rhinitis case. So we have to figure out if there is an allergic, a non-allergic, infectious maybe rhinitis. We can see here the signs that may be allergic one. So first of all, I would take a full history.
Yeah.
For example, what is the age of this patient?
So he's a young man, he's 25.
25 years old.
Sneezing, particularly first thing in the morning. He has some skin tests done, say, which show sensitivity to dust and dust mite. The rest of the panel is pretty clear.
Does it take any medication preventing his life?
He's tried antihistamines. He doesn't get any relief for them. Nasal steroids made his nose bleed. He's fed up with that. He wants an operation. What are you going to say to him?
If he has any previous surgery,
No previous surgery.
Skin prick tests, negative, positive?
To house dust mite. and
nasal
dust.
breathing test, some kind of nasal breathing test.
He hasn't had any of those.
So the patient is suffering from allergic rhinitis
Yeah.
or house dust mites?
Yeah.
Yeah.
Right, so what I would do, I would start with the intranasal antihistamines, and obviously he's fed up with the sprays, but I would give him a good chance to do this properly, explain how to use them correctly, so he will distribute and have them covering most of the layout of his mucosa, and then we'll assess the response. And I would do both eye drops and nasal spray, so to cover the...
He's a bit, you're having that conversation with him. He says, yeah, but doctor, every time I use nasal sprays, they just make my nose bleed.
You're talking about steroids. Antihistamines probably would not sort of do the same thing, because they obviously are different classes of drugs and they're not leading to the same symptoms. I would show how to use them correctly. I would also add on the salty water rinse to start with, and then use of the antihistamines in the nose. The next step would be to go to the oral antihistamines and seeing how things are with them. And at that stage, I would have these lovely pictures that you've done, because we also do endoscopies. A little bit less with COVID now, but in the before COVID time, allergy practice also has access to this routine procedures that you guys do. But we're also equipped. So we would do that, and then seeing to what degree there is deviation, or is there any structural requirements for you to intervene with surgery or not. And by that time we would know whether there is a response to treatment. If there is a response to treatment, we would discuss a desensitization program, and at that stage probably what the patient is wishing will be accomplished, so there will be less of the medication than in the nose and tablets, and then there will be mainly desensitization problem.
Okay, so you send him away with his nasal antihistamines, some oral antihistamines. You've scoped his nose. Actually, when you scope him with a bit of decongestion and you get a telescope in there, it looks really good. There's nothing else going on. There's no abnormal mucus trails or polyps or anything like that. Just very congested mucosa that shrinks back. So he goes away, he comes back and he says, okay, I'm a bit better, but you know, I can't get to sleep at night. I keep waking up. It interferes with my job. I feel tired all the time. Have you got anything else you would?
What do you think of immunotherapy?
So, yeah. Immunotherapy, do you do sublingual or do you do...
Sublingual.
Yeah, I mean, nowadays it's mainly sublingual because of, again, difficulties with getting patients in due to COVID and restrictions. But yeah, the immunotherapy, I think he would be a good candidate to have have the sensitization program. 3 years daily sublingual spray for 2 minutes every day.
Okay.
For the duration of 3 years, and then we would see hopefully effect in about 4 to 6 months. And if he's happy, he carries on for 3 years.
Okay. He's a bit of an unreliable sort. You know, he pitches up for his first treatment and he has that, and then he just doesn't turn up again. And then you don't see anything from about 6 months. And Marlene comes back to you in 6 months and says, listen, I've decided I don't want to have that treatment. My nose is really blocked, and I've seen another doctor who recommends that I have my turbinates taken out, and I thought I'd come to you as an expert for a second opinion. Would you take his turbinates out?
So probably I would like restart the whole thing, take his history again, do the testing. We usually do rhinomanometry testing on everyone who has a blocked nose.
Okay.
Also, we do smell testing. Then we do once again, an anterior rhinoscopy, flexible endoscopy, and see what the situation like, if something has actually changed.
Yeah.
If he says like he wants his turbinates out, and like it depends whether there's actually like an indication for that.
But will it help?
So would you?
No.
Well, let's say you come to an agreement with him that he's tried all medical treatment. He's not going to participate in immunotherapy. He understands the risks of not doing that, but he would like some attention to his turbinates. Would a turbinate complete resection be your first option, or?
We usually never take out the turbinates completely.
Okay.
What
do you do?
A mucosal resection.
Okay.
But seeing that it's not it wouldn't get rid of the problem.
Yeah.
It wouldn't be the first option to do.
So why do it then?
Yeah. So we wouldn't recommend doing it.
Okay. Rob, chop his turbinates out. Big pair of scissors.
Well, I'll have to pull this down because I can't really fully understand what they're saying, so you probably won't be able to unless I do it too. I have the luxury of seeing patients together with the allergists all the time. And when they're done doing the best they can, then they'll say, try something else. And I mean, I would do radiofrequency, submucosal, it's not a turbinectomy, it's just a submucosal procedure. It's very conservative, but it reduces the symptom burden. And I mean, maybe there's psychological reasons, maybe there's a lot of things, because then they're more willing to use the nasal sprays, and you kind of reset the bar, at least in my experience. And it's a simple office procedure. Some people that are a little bit jumpy, maybe you'd want to take them to the operating room, but usually you can do that in the office. In my experience, that's worked pretty well. But obviously you're going to exhaust the rhinitis management first. But
okay, so he has it done as an office procedure, and he loves it. He said, "This doctor is fantastic. I need a general anaesthetic," and he goes away. He's a happy punter, and then he pops back about 3 months later and says, "Listen, I was really good for the first 6-7 days, and it's kind of come back again. And can you help?"
Well, I mean, I haven't had that experience very often, but, I mean, then you could try allergy shots again or whatever. I mean, maybe I would probably get a CAT scan in that setting too.
Okay.
If you've got failure, maybe you're missing something. It's kind of hard to tell whether his septum is over on the one on the right there. Perhaps that might be another issue too. It's kind of hard. It's hard to really tell there.
I wasn't making it easy for you. What about, would anybody chop his turbinate out? Would anybody use any powered instrumentation? Would anybody do anything different?
I mean, if he's very wealthy, he can go for anti-AG injections, and that might stop his problem.
IG?
Anti-AG, omalizumab.
Okay, yeah, omalizumab. We can't prescribe that in the UK, unfortunately, but yeah. Okay, let's move on to our next case. That was a sort of fairly straightforward one that we're all sort of tasked with from time to time. In fact, no, let's stay on this a little bit longer. So this is a patient who, 25-year-old doctor, actually, and she has a history of nasal obstruction and allergy. She failed medical treatment and had inferior turbinectomy, and she actually had a partial middle turbinectomy on both sides. And she presents with a sort of sensation that her nose is blocked. You pop a telescope in and it looks wonderful. The nose looks really good, nice healthy mucosa, no crusting. But she is absolutely insistent that her nose is blocked. She's got no alar collapse. She's got nothing in her post-nasal space. She's got the sort of nose you look in and think, God, I wish my nose looked like that. Yeah, she's just absolutely convinced she's got a blocked nose. Mihail, at the end, what are you thinking here? She had a lot of surgery.
Yes, this is really a great problem, because previous doctor had resected the inferior turbinate, so the patient feel that the nose is blocked, is stuffy, and I don't know if we have a lot of things that we can do with these patients rather than increase the let's say the hybridization of the nasal cavities, just to make just to decrease the sense of stuffy nose.
Yeah, what would you be giving as a sort of working diagnosis here? She's had two lots of turbinates taken out. In fact, she's had an ethmoidectomy. Heaven knows why, because she's got lovely, healthy ethmoid mucosa. She's
empty
got
nose.
big
Empty
white
nose syndrome.
Yeah, empty nose. Yeah,
It's a serious problem, and they already did association about the empty nose syndrome, and we are reading so many discussions about it, and the patients, they're talking that they have difficulty during the breathing, but if you examine them, you can see that the both sides, they are not so blocked, and the problem is psychologically the first, and the second is that we have to take a good history from the patient, because we have to ask not only for allergy. You know that we have non-allergic, so many types of non-allergic rhinitis. Also, we have to ask so many surgery they did. Yeah. That's why I'm suggesting to do, for example, rhinomanometry plus acoustic rhinometry, and you can see reaction of the nasal mucosa. And also, I'm suggesting to take a scrub from the nasal mucosa and to investigate for some inflammation. For example, eosinophilic inflammation.
Yeah. So you do all these.
And mucociliary clearance also to investigate.
Okay. So you do your allergy testing. It comes back as very mild, let's say mild response to pollen. She has her rhinomanometry, acoustic rhinometry. It doesn't really show very much, a little bit of improvement with decongestion. And you say to her, listen, a lot of this is in your mind. And she goes absolutely nuts in front of you. She's really not happy. She says, I absolutely can't breathe through my nose. And she seems like, she's a doctor. Doctors are pretty sensible, aren't they? Yeah. You know, is there anything else we can do to help?
So from the conservative environment, I mean non-surgical. Firstly, it's based on the pictures. It's hard to imagine what else is it possible to cut out. But I think probably that won't be a good approach. We need to do just make the confirmation that there is indeed the blockage is happening due to swelling of the mucosa, and that's really what is happening rather than some sort of problems with the airflow. So again, with the acoustic rhinometry, it should show us if there is an obstruction, there is a sort of point of looking into it. Again, whether there is a problem with the mucociliary clearance in the nose, so that the saccharin test or something similar might help to find out whether there is sort of transport or it's not. And probably doing a CT scan just to see whether that's there is something else that we cannot see from the endoscopic pictures. That's kind of medical approach to it, and obviously trying to do sort of anti-inflammatory treatment.
So you're looking at all the sort of alternative options, and you do all those tests, and they all come back really not pointing in any particular direction. And she has a CT scan that shows a little bit of mucosal thickening in her maxillae, but the rest of it looks pretty good. She's had her ethmoids done, so not much going on there. And she comes back with a bit of paper, has done a bit of research on the internet, and says, listen, there's a doctor in the States who is putting fillers in, who's putting implants in the nasal cavity. Is that something that you would do, doctor? Would you put a spacer in and
refer her to the States?
Recreate my
to that doctor.
Marlene?
Doing a referral.
I've actually had a patient with an empty nose syndrome, and she kind of also wanted like more and more surgery. We would actually be quite conservative and rather like start her off, for example, like nasal rinses. Also see whether there's a difference between the sides. See whether she has other, like for example, she's smoking, and you can kind of get rid of this, like to make everything to get back a healthy mucosa.
Okay, that's fine. I think we've done this one to death, so let's move on. I'm going to just move on and ask a little bit about. Let's talk a little bit about septoplasty. We've got a posterior septal deviation here, and if I move forward, we've got an anterior septal deviation. Rob, do you do any pre-op particular assessments in patients who present with a deviated septum in association with nasal obstruction? Do you believe in that the headlight is as good as, and an endoscope is as good as anything else, or do you need to do PROMs and rhinometry?
No, I don't do any of that. I have a relatively low threshold for a CT scanner because we have the portable one in the office, which is, again, a luxury. But if their only symptom is nasal obstruction and they're young and healthy and they have no other confounding issues, I wouldn't do anything else other than endoscopy.
Okay, yeah. Rest of the panel, does anybody do any special investigations on these patients? Rob does a CT. Does anybody do any airway assessments?
We always do a smell test, and we always do rhinomanometry before septoplasty.
Is that obligated, or do your purchasers expect you to do that?
I think it's we don't really look at you don't really expect much from the results, but I think it's also you can maybe compare the before and afterwards, but like also it pays the bills.
Okay.
Get a CT scanner, you'll be able to pay more bills.
What about patient-reported outcomes? Does anybody do a nose score or SNOT 22?
I think that this patient has a problem with the nasal valve. And when we are touching the nasal valve, it's a serious problem during the rhinoplasty. And then you can do reconstructive surgery, a second rhinoplasty, but not successive. Then the patient's coming to you and telling you that they cannot breathing. And I think that here the problem is nasal valve.
So that's, yeah, it's a bit more challenging, this septum, than the previous one, isn't it? You know, doing a deviation in the mid-septum is a lot easier than doing a deviation anteriorly. So, you know, some people would do this as an open approach, an open septoplasty. Some people would do a closed procedure. What would be your favourite approach, Mihail?
In any case, we have to approach the nasal valve. If we just go on with septal rhinoplasty, the problem still will continue. So I will approach the nasal valve external, open, because I don't have so much experience on this. So I prefer the open approach than the.
And let's say that's a vertical fracture, about half a centimetre back, 3/4 of a centimetre back from the columella. Single vertical fracture. How would you manage that? Do you excise a fracture, or do you work around the fracture? Do you do an advancement? How do you manage those?
Me?
Mm-hmm.
Yes. If I don't know what is the distance from
About half a centimetre, 3/4 of a centimetre.
Yeah. I will go on with an open approach. Yes, in any case, and in order to repair this nasal valve dysfunction. I don't know.
Dilyana?
Close approach.
Closed approach. Okay, and what do you do with that fracture line?
Yes, look, the problem is that the facial plastic surgeons, I'm not talking for rhinologists, because we have to compare how is working and so many approaches. They don't using these methods for nasal breathing tests like we are using, for example, rhinomanometry, acoustic rhinometry, etc. Why I'm telling that? Because it's very important to do pre-operatively. For example, you can do rhinomanometry and acoustic rhinometry to see where is the problem, the real problem, before the rhinoplasty surgery. And then you have to find the special place which is the nose is blocked on the right, on the left side, and then you have to discuss what kind of surgery you can do: open approach, close approach, or what is the better for the patients. And finally, you have to discuss with patients what you will do. If you are not discussing what is happening, I'm telling for my country. If you're not discussing with patients anything, and you can say just, okay, you want a nice, beautiful nose, and I will do my best job for you, and I will do special rhinoplasty for you.
So
but after the surgery, what is
let's
happened?
just a second. This patient doesn't have any concerns about the appearance of the nose. The nose is straight from the outside. There's just this.
I'm talking generally, Sean.
Yeah.
Yes.
So
I'm talking generally that.
but what
we're
would you?
studying now them.
Yeah. What would you do for this patient?
Okay.
What would you do for this particular one?
For particular one, I will start first to do rhinometry to see what is happening, and
what
then
would be your surgical approach, though? How would you?
the surgical close approach.
So yes, and would you excise a fracture, or would you advance some quadrilateral cartilage? What would you do?
Advance the cartilage.
Okay, that's fine.
Okay.
Yep. No, it's interesting. There are lots of different ways of doing it. What about medical therapy for deviated septum, Michael?
Say this again, sorry.
Medical therapy.
Medical therapy, we can unblock the nose to as much as we can, but I, to be honest, not aware of any that will help. Obviously, you can reduce the swelling if the swelling, depending what's the cause of the swelling. And that's pretty much it. So then it's all in your hands.
Yeah. Okay, so it might be worth trial of medical therapy. The patient's happier with that than having surgery.
The medical therapy we can, but obviously it will not fix the problem 100%. But if there is the underlying cause related to allergy or related to infection or related to something that is fixable, it's possible to fix that. But afterwards, if it is because of the anatomical issue, until you fix the anatomy, it will be still the problem.
Okay, let's just move. We'll move on to something completely different. What about this? How do you manage? This is a septal perforation. We can see decent size of perforation here, 2.5 centimeters. This patient pitches up, blocked nose, bit of bleeding from time to time. Otherwise fit and healthy. You know, person in the 30s, at work. But just fed up of all the sort of chronic crusting and discomfort associated with that. Looking from the outside, nose looks absolutely fine. No issues at all with support. So there's no saddling or anything like that. Marlene, how do you assess septal perforations? What's important points in you taking your history?
I would ask her. You were saying, I think she's in her 30s, right?
Yeah.
I would ask her whether she has any systemic disease. So I would be thinking of, like, for example, Wegener, whether she has maybe consumed any drugs.
Yeah. Does that look like a Wegener's perforation or a cocaine perforation? Do they tend to look like that?
Not really, no.
It's a bit too clean, isn't it?
Yeah.
Okay, but yeah.
But I would, nevertheless, I would always inquire. I would ask whether she's been picking her nose, whether she's realized it, whether she's any problems, whether she's on like anticoagulation, how often it bleeds, and then potentially if she has issues, like see what we can do as the next steps.
Okay, so the history is not really very clear. She sort of denies picking her nose, but you kind of look at her and she's got a bit of blood under her fingernails, so you're a bit sort of suspicious about what she's up to. Do you do any special tests on these? Do you biopsy them? Do you measure their ESR? Do you do their ANCA?
We would, we would do blood tests, and also we would take a biopsy.
Okay. Do you do that in every case?
Where it's unclear, yeah.
Okay.
Where it's clear, where people have been saying that they've been taking drugs, like the indication is pretty clear. But just to rule it out, we would take a. Okay. If it's not clear, we would take a biopsy. Rob,
do you do them all, or?
When I was a young man, I would do a biopsy and a whole bunch of blood tests, and it rarely does it yield anything. I would still probably do the blood test. I'd probably try to talk one of my partners into doing the case, because they don't. When I was young, I was enthusiastic about doing an open approach and trying to rotate that intact septum forward and making it all nice. But these cases tend to be unrewarding. But now that the PDS implants, those little plates, they do work. I think, well, they work better than nothing. And the Biodesign implant, too, was a nice upgrade over the old days when we just sort of rotated it together and sewed it up. But the external approach does give you a lot more. With a rider needle holder, you can kind of get in there a little bit better and do a much better job than trying to do that through the standard approach would be problematic.
Quite a big hole, isn't it?
Yes, it's a big hole. I wouldn't be enthusiastic. As I said, give that to my partner. He can.
Yeah. And let's say you have that conversation with the patient. You say, well, there's a surgical option, but it's a 2.5 centimeter perforation, and you can swing various sort of flaps into these as well. And the patient kind of begins to turn a bit green and says, "Oh, I don't fancy an operation that big, doctor." Is there anything else you can do without operating? So, Mihail, at the end, is there anything, Mihail, that you would, non-surgical options for patients with septal perforations?
This can take, it's very difficult case because the perforation is very large, and I'm suggesting to take mucosa from the inferior terminate, if it's possible,
And what
to close the defect.
So take a...
No, you're removing you're doing preparation.
Yep.
On the inferior terminate mucosa and on the floor of the inferior channel, and then you can go up if it's possible.
Okay, so yeah, you sort of say that to the patient as well, and they say, no, actually, the more you tell me about it, the less I want an operation. So can you do anything else other than operate on me, doctor?
It's very difficult for treatment because I have...
Any conservative treatments?
Yes, conservative treatment, okay, you can give them the nasal oil. Why? Not nasal. Why oil? Because we have to renovate mucociliary clearance to work and to nasal breathing to be more easy for this patient.
Okay.
This is my opinion.
Would that be your sort of medical management as well?
Yeah.
Michael, if you saw this patient?
Yes, I agree with Dilyana. I would go on with operation. Otherwise, because in case that the patient faced problems, if the patient has bleedings, has a feeling of nasal obstruction, otherwise, and if the patient was negative for the operation, maybe I would think for septal button, but I don't know if it will work in such a great, large perforation.
Okay, so yeah, I think that sort of, the conservative management's appropriate as well, and as well as sort of surgical options, and it's just important for the patient to be able to weigh up the risks and benefits of them both. So let's move away from the septum, because that's all far too exciting. And here's a patient who presents with nasal obstruction, and you look in the nose with a telescope, and this patient is not an asthmatic, but has got a very poor sense of smell, progressive nasal obstruction, is on topical corticosteroids, gets a little bit better with courses of prednisolone, but then symptoms tend to come back again. I know it's only a single picture, but Michael, does that look like a good prognostic looking polyp? Is that the sort of polyp you look at in clinic and think, actually, that's going to be a nice operation?
To see what is the prognosis, we have to do a lot of things. First of all, I would, except of CT scan and endoscopy score, I would go on with blood tests in order to measure the eosinophils, the IgE, the neutrophils, in order to figure out what the type of this inflammation, because it's probably Th2 type of inflammation, because you can see in the CT scan that there is a severe rhinosinusitis with nasal polyps. I will ask the patient if the patient had previous sinus surgeries. It's the first time.
So yeah, patients had no sinus surgeries in the past, not asthmatic.
Okay. So from the blood tests, I would see the values of the IgE and the eosinophils.
So IgE is high, let's say, and he's got a aspirin sensitivity.
Okay. So this is a severe CRS with nasal polyposis case. I would think what's going on with the operation, and then I would take also the nasal polyp, and if I have the possibility to go on also to the lab to examine, to find out also the IgE in the nasal polyps, the eosinophils, the ECP in the nasal polyps, and also to come to a conclusion what's going on with this patient.
So, Dilyana, you look at that CT scan and you look at that polyp in combination. What do you think of the two?
What I can say that I'm not sure that this is only the nasal polyps, polyposis. Why? Because chronic rhinosinusitis with nasal polyps. Why? Because if you're looking very carefully on the orbits, we have some. I'm not sure, but I think that we have some bone distortion of the inferior wall, And if you're looking
yeah,
here,
I see what you absolutely just on
and
the
of
inferior
course
margin,
we
but
have
actually
deviation also of the nasal septum, and yeah,
it's a sort of partial volume defect. That's not, it's not a real defect.
it's not a real
No.
defect. Yeah. Okay, we immediately have to do surgery, and we have to do surgery, but it's only one side of the CT scan. I want to see all CT scan because then I can do my management for this kind
Okay.
of surgery.
So I show you the full CTs, and essentially it shows you that it's pretty much like that throughout all the sinuses bilaterally. Michael?
Right, so you said that there were problems with aspirin, and that might be the underlying factor that's sort of increasing or predisposing this patient to get recurrent and more sort of prominent disease. And you said that there is nothing on the asthma side, so making sometimes tried a little bit kind of incomplete, but probably to be the actual diagnosis. My sort of discussion, obviously that the patient needs an MDT from the point of taking decision of what to do. From my thinking, probably to do the surgery first, and after it all heals nicely, starting him on aspirin desensitization intranasal with aspirin lysine, and doing it as a sort of challenge test that converts into the desensitization program when we reach the reactive dose. And then they will be doing it themselves at home with this, just dosing the aspirin, lysine in their nose every day, and that's how probably I would manage it. It's not a simple case, but I think it's manageable long term. But it needs to be done jointly by ENT specialist and allergist.
And what about putting him on a low salicylate diet as well as desensitizing him? Do you think that makes any sense?
Say it again, sorry.
A low salicylate diet.
To be honest, it might do some sort of sense, but I don't think that it will cure the problem.
It's a pretty miserable life in being on a low salicylate diet, isn't it?
It is, but it's kind of avoiding it's very difficult because it's all in all packaged food and everywhere. So it's something that will make the life difficult. But the question is whether it will fix it or not.
Okay, yeah.
That's
Marlene,
the question.
can I ask you? You know, we agree on surgery, and then we're going to talk about desensitization, as Michael says. Well, how much surgery are you going to do here? As we say, he's got pretty well ventilated. He's got well-developed frontal sinuses, but they're chock-a-block. His sphenoids are chock-a-block with disease. How much surgery are you going to do? Are you going to do simple polypectomy or antithymodectomy, or how much are you going to do?
We would probably do infundibulectomy combined with an ethmoidectomy, and depending on the sphenoid.
Yeah, it's full of
Then also,
chalk up.
yeah.
Do sphenoid.
And maybe also think about a small deviation.
Okay, yeah, and you do a septoplasty, I suppose, if you need to access septoplasty, limited septoplasty. You might be able to get beyond that, it's fairly low. But do you do his frontal sinuses?
Depending whether it's blocked or not.
So they're chocker as well, they've got
Yeah, we
they're
would
well
also-
opacified. He's not got much in the way of headache or anything like that, he's just sort of blocked up and poor sense of smell. Do you do his frontal sinuses?
Probably yes, just to get the drainage.
And what do you do? Lothrop or?
Just with the simple access and
Okay,
that's it. Not
so some draft 2 or some draft 1, draft 2, something like that?
usually just draft one.
Okay, that's fine. Rob, what do you surgically, what would you
Well,
do? Anything different?
it does worry me a little bit that osteometal area on the right looks widened. Now, that may be an artifact,
Yeah.
but it does worry me that might be an inverted papilloma in the presence of AERD, but, I mean, you can operate anyway, you can worry about that later. But I would do these, it's unusual to get a shot at a primary AERD, usually it's the third time. I would do draft 3 right from the start.
Okay.
drill them out. I started that about 10, 12 years ago. P.J. Wormald convinced me that was the way to do it, and this is somebody that's likely going to need a biologic.
Okay. Yeah.
So we would have that we'd have a low threshold for that.
Yeah.
You'd follow them very closely for the 6 months afterwards, because in my experience, they're almost assuredly going to fail.
And what's your, those of us who work in the third world in the UK, we don't have access to biologics routinely. Tell us, how do you choose who to give a biologic to?
Well, the AERDs, again, in my experience, the majority of them will end up needing it.
Yeah.
Other than that, be patients that have failed a couple times, particularly within 2 or 3 years.
Yeah.
But it's a little bit arbitrary, but they are wonderful. And I like them post-op. I know that you're supposed to use one or the other, but Klaus just presented some of his stuff this morning. 15% of the patients are quote-unquote cured at a year after $38,000 of a biologic. To me, that's not good enough. I would do the surgery, which adds a minimal amount of extra money when you compare $38,000 a year that they're going to have for the rest of their life. Do the surgery, and then you are likely going to, in my experience, those are the patients that have snot 22s that are tiny, that are happy as clams. It's a minuscule amount of extra dollars in the grand scheme of things.
And what's your biologic of choice? Do you just sort of toss the coin, or are you sponsored by somebody, or?
Well, I see patients with the allergist, which is a great luxury.
Yeah.
So they really sort of manage that. But the dupilumab is presumably the most efficacious. So that would be, unless they have really high eosinophils, we would tend to favor dupilumab. My experience with omalizumab has not been very favorable, but I'm not that convinced that there would be any difference if you give it to them immediately post-op. Because if you're trying to reduce this disease burden, the massive polyps everywhere, dupilumab at least appears to be better. But if you're starting it with a polyp score of 0, and a symptom score that's very low, as you are in the first few months after surgery, I don't know, any of them may be able to block the cascade that gets out of control. Now, I don't have any real evidence for that, but before we had dupilumab, mepolizumab was working pretty well if you use it that way, at least in my hands, post-op for these severe patients.
And Michael, in terms of sort of a clinician or a physician's view on that?
Yeah, I'll tell you in a second, but let me ask you a quick question. With the dupilumab, in your experience, would it be, sort of in terms of conjunctivitis in this group of patients, will that be a problem or not?
Would be, I'm sorry, for the ERD patients?
Conjunctivitis, yeah, for this group. So when you start post-op dupilumab.
When I would start it?
No, what percentage of them would get conjunctivitis due to the drug?
What percentage get a bad reaction to the drug, or I don't know?
Yeah, so with dupilumab, the conjunctivitis is one of the recognized issues.
We see a handful of patients with the uveitis or the arthralgias and things like that, and there's some people who failed dupilumab, they still recur. So I'm not on the dupilumab team. I'm not trying to say that, but there are some patients. Again, I have the luxury of having an allergist there to manage these issues, but it's been pretty low. We've had a handful of patients. I can count on one hand the ones that have had some sort of the arthralgias, arthritis, or uveitis, things like that where they couldn't tolerate it.
So in surgical patients, it's not as prominent as with dermatological patients, for instance, from your experience.
I have so few patients that we just put on because it's easier to get surgery approved than it is to get the biologics approved. So they all tend to get surgery, and then we fight, argue with the insurance company until they get that approved. So, I don't know whether the surgical patients are more likely to have a reaction or not.
So a sort of consensus seems to be surgery first, and then biologics if you have access. Let's move on to another case. Let's go on to let's try something different, shall we? Yeah, you were talking about Lothrop, cases. Michael, at the end, do you do low-throat procedures?
I prefer draft 2B or draft procedures.
Yeah, do you ever sort of have your
For
arm
the-
twisted
for-
into
for-
doing a
for
draft
the-
3 from time to time?
Yes, from the frontal sinus.
Yeah? Do these pictures sort of ring a bell? Looking up post-operatively, that would be, first one on the left is sort of week post-op, second one's about 3 weeks post-op.
Yes.
The fourth one, the third one there is about a month, 6 weeks post-op. And at that point, you're kind of patting yourself on the back and thinking, that's a pretty good operation, look at that. And then this is about 9 months post-op. It's beginning to close down. The mucosa, I mean, it doesn't really matter about the background of this patient, but the mucosa is a bit worrying, isn't it? It's pretty unhealthy looking mucosa. It kind of reflects that sort of background chronic sinus disease that the patient had their surgery for, first of all. What do you do when you get to sort of that point? That point there at about 9 months when it looks like it's beginning to close off a little bit. Is there anything you can do there, or do you just sort of say, I hope the patient doesn't come back to see me?
I think that the frontal sinus is the most difficult sinus that we have to operate because it closes a lot. So I think that very important for a patient is to have a post-operative monitoring, close post-operative monitoring, maybe to use corticosteroids in the nasal, in the frontal sinus. And
is that in a rinse or injected or a cream? How do you do that?
To rinse.
Rinse, yeah.
Yes, in the frontal sinus.
Is that in a sort of squeezy bottle of some sort?
Especially for a period in the first 6 to 9 months, where the mucosa, the new mucosa is healing, and to see if after that period the opening is still wide and safe for the patient.
Okay, no, that's all. That's good. Let's move on to another case. So this is another case of a low throp. When you hear people sort of stand up and they say, and this is a case that was referred into me, but that was done by somebody else. This wasn't. This was a case I did, and this was about sort of 6 or 8 weeks post-op. That's a low throp procedure, and what you can see there at the bottom of the screen is the nasal septum, all very bulky and boggy, sort of polypoid changes, and then you've got these sort of 2 enormous heaped up scars running down either side of the lothrop, and already at this stage it looks like it's beginning to seal off. I injected those with triamcinolone, I think it was some time ago, and then patient came back a time later, and this is a couple of months down the line, and what we're seeing here is the complete obliteration of that frontal sinus outflow tract. It's a great operation when it works well, low throp, but it doesn't always necessarily work quite so well as you would hope. So, Dilyana, do you do low throp?
Yes. Post-operatively, the nasal washing is very important. Saline with corticosteroids, and we have to check the patient. I can suggest every month because we can see what is happening with the nasal mucosa and investigate. What would
you do here? So the patient initially presented with chronic rhinosinusitis. He had a mucocele, as you often find in these sort of ARD patients, out of the lateral aspect of his frontal sinus, with a bit of erosion into his orbit and his anterior cranial fossa. So we had a low throp to kind of get access to that. We cleared all of that out. He comes back, his orbit is still soft, he's not got any proptosis, he's got no headache. Do we sit tight, or do we give him some steroid, or do we reoperate, or do we send him to a friend?
If I see the CT scan, it will be much easier to answer you.
Yeah, well, the CT scan, actually, Well, I don't have the CT of him, but it essentially shows that he's got well pneumatized frontal sinuses. He's got a lot of new bone formation, as you often see in these patients, a lot of osteoneogenesis floating around on the margins and down the side of his low throat. He's a sort of chronic inflammation there for perpetuity, really. These are not, they're not, the audience, these are not easy cases. These are difficult cases that we all have to put up with sometimes. What would you do, Dilyana?
What I'm talking, that it's very difficult cases, it's complicated, that's why we have to see some more details about the case.
Okay, I won't put you on the spot
Okay,
then,
can
Marlene.
you open the next one?
I have no more slides on this one. Marlene, what would you do?
Right, while I'm passing on the microphone, just maybe the new one from the back of our program, the new implantable steroid thing.
Yeah.
No?
The drug-eluting stent, yeah. Marlene?
Yeah, I think like since this patient has been bothered with loads of inflammation and chronic infection, it's probably if it totally obliterates it, the chance is quite high that we have a recurrence of infection. So you might want to find something to open up the osteum again. Maybe this Propel drug-eluting stent, maybe. I'm not sure, did the 3M, did that work?
Rob, what do you...
I misunderstood. Is this somebody that had a mucocele in their frontal sinus or somebody that had AERD?
So they've got AERD and they also had a mucocele out with a bit of orbital erosion.
And right now, they're asymptomatic with air in the sinuses?
They've got a pacified sinuses, but no recollection of mucocele. It's just... And they've not really got much in the way of symptoms.
If they're pacified, then it's just a matter of time. But I wouldn't bother with any steroids if they're breathing well. You just watch them closely, or you can, whenever it's convenient, I would reopen them up. I mean, this happens. Everybody has these cases. It just happens, and redo it. And sometimes the silastic sheeting, if you roll it and you let it sit in there for a month or something like that, it'll heal better. Maybe not. But that's what I would do. I think you're going to end up having to redo it. It's just a question of when.
So that's the redo Lothrop is something that anybody doing this sort of surgery has to be prepared to do. Rob, any place for an external approach? So would you? I know you haven't seen the scans, but just in theory, would you think about obliterating his sinuses or opening it top and bottom, drilling out all that new bone formation?
I did 25 as a senior resident, and I haven't done 25 in 30 years of those obliterations. So I would be reluctant to put somebody through that. You can do it in, with the drills are so nice now. It's a pretty easy, even if you had to, and I'm not sure, depending on the age of the patient, those things recur. I would be very reluctant to do an external an obliteration.
Anybody else think about doing it externally? No, nobody in the panel. Okay, let's move on to something else. Here's a 50-year-old fellow, presents with blocked nose, long history of nasal obstruction, and he's had this sort of discharging sinus on his forehead. He's had it for years, at least when I say years, at least a couple of years. Doesn't really give him very much trouble. Went to see a local plastic surgeon who had a look at that and was a bit concerned it might be a BCC, took a biopsy, came back as inflammatory, and he arranged for the patient to have a head scan. So if we just have a little look, that's when you kind of clean it up a little bit more, he's got that little bead of pus, and that's the patient's head scan there, or sinus scan, so you can see he's got pacified sinuses. Anything else you would comment on about those scans? Mihail, at the end, anything?
Yes.
Anything of interest on those images?
Yes, there is a problem in the frontal sinus. You can see in the CT scan.
Yeah.
There is a lack of the frontal part of the frontal sinus.
Yeah. posterior table's missing there, isn't it?
And not only posterior, I think that anterior also wall.
Anterior, yes.
Yep.
Yes. And I don't know if the clinical status of this patient was urgent or not, because it needs maybe urgent operation here.
Yeah, so no, he just he kind of walked into clinic and said, plastic surgeon took a biopsy of this and a bit of inflammation. And then he organised a CT scan, and he didn't want to see me again. He said, "You're the doctor that I need to see." And he's fine. He's got no, other than a bit of blocked nose and that discharging sinus. He's otherwise absolutely cock a hoop. He's very happy. And then these are his sagittals and his axials.
Anterior wall, yes.
I think that in any case it needs operation, and you have to go on endoscopically, but also you have to do an external approach in the frontal sinus.
Why an external? Just interested to hear your thinking behind that. To get access to that defect.
Yes.
Defect here and here, anterior
Okay.
and posterior.
Yeah.
Any other imaging you might think about?
What about an MR?
Yeah, okay, so we got him an MR. Why would you ask for an MR, Marlene?
Because you might want to see the brain.
Yeah, so you're a bit concerned about that posterior table. And there's his MR scan. So you can see there's no communication between the lesion and the intracranial space. His dura is not enhancing. He's got obviously a subcutaneous collection you can see there. So what are we going to do with this fellow? In fact, what's the diagnosis here? Any thoughts? Any of the panel? Well, we assumed it was sort of chronic osteomyelitis, a sort of chronic frontal sinus infection. It's got into the bone, and it's caused that sort of defect anterior and posterior. It's certainly nothing acute. He's not got a particular swelling there. So how might you manage him on the basis, Dilyana, that he's got a sort of chronic infection in his frontal sinus, in the bone there? If we go back to his CT images, I don't know if those help you at all.
He has not only on the frontal bone, he has also maxillary sinusitis. And totally we have to investigate what kind of microorganisms and if there is inflammation of osteomyelitis of the bones. And probably he has also the osteomyelitis of the maxillary sinuses. I don't know. And that's why we have to do emergency surgery and to open, but intranasally.
Mm-hmm.
And then we have to do antibiotic combination to do what kind of osteomyelitis, which is the microorganisms. And we have to follow every day what has happened with this patient.
Okay, so that's what we did. Essentially, we did an endonasal approach to that.
Because we don't have any arrangements of the brain. I'm looking at it.
It's not involved, but we did a sort of full house phase, opened it up, took some specimens for culture, and on the basis of the culture, put him on the long-term antibiotics. So we didn't actually do anything more than a sort of draft one to evacuate the secretions from his frontal sinus, put him on long-term antibiotics, and actually settled down, because initially we thought he might need an external exploration, and clearly that would need to be held in reserve if he didn't settle. But actually on 3 months of IV antibiotics, the whole thing sort of settled down, much to everybody's relief. Okay, how are we doing for time? We've got about 20 minutes left, so let's move on to something else. Yeah, so Marlene, this patient is a fellow, he's diabetic, he's in his sort of 70s, and he presents to his optician with some deterioration in his vision in the left eye. His diabetic control has been pretty poor. over the years. He's got a high HbA1c, he's a bit unkempt, he lives by himself, and he's had this sort of horrible discharge from his left nostril. He pitches up in clinic, and you look in his nose, and he's got a lot of mucopus sitting in his the floor of his nose. You pop a telescope in, and he's got a lot of polyposis, what looks like polyposis. Doesn't look malignant to initial examination. It looks like it's relatively smooth polyps in association with some pus. You assess his cranial nerves, and he's got a bit of restriction of movement in lateral gaze. In fact, he's got a bit of restriction movement in all planes in that left orbit. His vision's not very good on that side, yeah, you're a bit worried about him, really. What would you be thinking about? So that's his scan there. That's his anterior cut. That's a sort of more posterior cut. And then if we look at an axial soft tissue cut, we've got that sort of appearance there.
Yeah, so you're worried that he might lose his sight completely, his vision, because of a potential infection?
So he's sat at home for a couple of weeks with pretty poor vision. He's not really engaged with sort of medical services, but he's pitched up to accident emergency because things have got a whole lot worse in that, which is his poorer seeing eye. So you can see on his imaging there. What do you think about that axial cut? Any comments on that? He's got a bit of sort of double density in that that maxillary sinus, hasn't he?
So you're worried about his orbit. So you would start him on antibiotics and then get him into surgery.
Yeah. So indeed,
emergency-wise.
Got him on, put him on some IV antibiotics. Got him on the list the next day, and opened up, removed all the polyposis, and got a histology, and the histology just kind of came back as inflammatory initially, but we were a bit concerned about his orbit, so we got some further imaging, and you can see the sort of MR
told us that he's diabetic.
imaging there.
Which means that
So that actually I should go back because those are the pre-op images. So you can see he's got, on that axial cut, he's got a bit of inflammation, mucosal edema on the floor of that maxillary sinus and the body of the maxilla, but he's got this abnormal soft tissue under the floor of the orbit there, you can see, on that axial cut, that sort of low signal lesion. And then if you look at the image on the right there, he's got what looks like really abnormal tissue at his orbital apex on in the pterygopalatine fossa on that left-hand side of the patient, and also just kind of into his cavernous sinus as well. So what sort of things are going through you? Rob, any sort of things that are going through your...
I'm presuming this is mucor, and
Yeah.
you're going
Yes.
in, it looked like there was bone destruction on the first CT. I mean, you would just go in, clean it out. You're not going to take out his orbit or his eye, but you clean it out, get cultures, start him on whatever, antifungals or whatever, and then you're going to, if you're lucky, his immune system will recover and he'll do okay. Because, when I was a resident, we were taught to just cut until it stops bleeding, or still, until it bleeds a lot, basically. But I think that, the trend now is to be a little more conservative and let the tissue declare itself a little bit. But really, if their immune system doesn't turn around, they're not going to make it.
So you do as much as you can safely to debulk all of that. Obviously, as you're getting in towards that pterygopalatine fossa and the orbital apex, you've got to be careful. The anatomy is very distorted. It's all very inflamed. started off on intravenous antifungals, and I suppose the lesson here is that you might think this is malignant. It's certainly, with all that sort of bone destruction initially, you might think it's malignant, but we need to think about fungal disease as well, and particularly in the COVID era, with mucor in particular associated with a sort of poor diabetic control and indiscriminate use of steroids. It's the black fungus is a big problem in certain parts of the world at the moment. Okay.
You aren't seeing a lot of that here, are you?
We're not, well, certainly not in the UK. I don't know about other parts of Europe, but I've actually seen a couple of cases related to COVID, both of whom had flown in from the Indian subcontinent. But
India, and then I've seen the AE for laryngoscope. I've seen some from Egypt, but we haven't seen anything.
Yeah. Okay, so we're doing, well, how are we doing? We've got another 10 minutes or so, so let's move on to another case, if my panel can bear it. So this is a patient. I don't have CT images for this patient. The patient basically presents with right nasal obstruction, otherwise pretty asymptomatic, no bleeding, non-smoker, and has a CT scan which shows there's a bit of a pacification in the right-sided paranasal sinuses. You pop a telescope into the nose, and it doesn't look like normal sort of nasal polyp. It just looks a bit sort of sessile and slightly irregular in appearance. So what sort of things might be going through your mind here, Michael, at the end?
Yes. I don't know, first of all, if we have taken biopsy after the MRI.
So, let's assume that somehow the patient arrives with an MRI scan,
Yeah.
and you see them in clinic, and they haven't been biopsied. So that's a good question. Would you think about biopsying it in clinic?
Not always, because in some cases you can take the biopsy from a point in the nose and it will be negative, but it depends on the clinical history, on the CT scan, on the MRI findings, but also if you want to plan your operation. But here I think that's something. It's a unilateral disease.
Yeah.
So my mind would go to neoplasm and maybe.
Yeah, those are as sagittal cuts. What do you think about those sagittal cuts?
And
Yeah. Yes, maybe an inverted papilloma.
Yeah. Would you
Many
biopsy this in clinic? Yeah.
I would take, yes, biopsy.
Yeah.
Yeah.
So yeah, I think it's a sort of interesting discussion about who do you biopsy in clinic, and there are a number of factors associated with it in terms of the patient's general health and what sort of medication they're on and what the size of the thing is. And I think when you have a look in clinic with a telescope, you kind of get a good feeling about whether you should take a bit of experience. You get a good feeling about whether a biopsy is a good idea or not such a good idea. You might not want to think about biopsying a unilateral polyp in a 15-year-old lad in clinic, but a fellow in his 70s who's brought his own MR scans, and you can sort of see this. That sort of age, 70-year-old, otherwise sort of fit and healthy, no sinister features associated with him from a clinical perspective. What's your number one diagnosis? I think, Dilyana, you said it already. Dilyana? What did you think it was?
about biopsy, you are asking. We have a standard, and the first history investigations, then we have to do CT scan, sometimes CT scan with contrast in some cases, MRI, and then we can discuss to do biopsy if we have differential diagnosis for some tumors and for
so let's
some
say
other,
you do biopsy. What are you expecting here? What would be your number one diagnosis?
for me, inverted papilloma, I'm thinking.
And that's what what do you think? And is it inverting papilloma? Is that a tumor you can just leave and you know, a 70-year-old and say, you know, you'll be fine, it's benign, that doesn't cause any problems? Or do you operate on them all?
Probably of us.
Marlene, do you operate or do you leave alone? What would you recommend?
This is a 70-year-old
Yeah.
fit. Yeah, we would take it out.
Yep, okay. And how extensive a procedure would you do for something like that? What would you
Well, it can potentially be malignant, like you could potentially have a malignancy, so you could like take it all out and then follow up on the patient.
Okay. And looking at those scans, do you think it's going to be relatively straightforward to take out, or are there some areas on those MR imaging that just make it a little bit more tricky than you might?
Yeah, of course you have to take care about the orbit.
Yeah. The orbits, obviously, some concerns about that. I mean, the frontal sinus looks pretty straightforward, doesn't it, Rob?
Yeah. I mean, I think so. It's a little bit hard to tell. I like CT scans better, but yeah, I mean, presumably it's not attached up high there.
No.
Presumably.
No, it's just a sort of single polyp almost sort of growing up into the frontal recess.
Then you're probably okay.
Yeah. The maxilla is a little bit more of a challenge, actually, isn't it?
Yeah.
It's just kind of, when it starts growing out laterally and it starts going inferiorly, they're just a little bit more difficult to be confident you're getting all out. It's lovely if it's a sort of single polyp that's growing in that direction and it kind of just delivers itself, but when it starts attaching itself, then it's more difficult to get out there and remove it. And if its attachment is out there, then you've got getting a drill in there to drill the attachment down so that it doesn't recur can be a little bit more difficult. But no, that was relatively straightforward, and he was fine. Okay, we might be coming towards our last one. I think we're at about 8 minutes past the hour, so let's do this one. So this is a lady in her 50s who presents with a bit of left-sided proptosis, gradual onset. Her vision is fine. She doesn't actually have a blocked nose, so maybe I shouldn't be bringing her here, but she just has this sort of bit of proptosis associated with this. Mihail, do you have anything you'd like to comment on?
It's not mucosal.
Do you take the
It's not.
the microphone?
No. I'm just quickly noted that it's not mucosal because we have damage of the orbit and we cannot see the wall. And what you can see, yeah, frontal sinus also is arranged. And can you continue, please? It's coming probably from anterior cranial fossa. Am I correct? Meningocele?
So what would you, on seeing those images, what would you do next?
This one.
Yeah, would you do any further investigation?
We have, yes. And probably is meningocele or...
So how would you make that? How would you make that diagnosis? Would you do any further imaging?
I'm thinking for differential diagnosis, that's it.
Yeah.
MRI?
Yeah.
Okay.
MRI scan. We don't have the MR here, but in fact, there was no evidence of anything coming through from the cranial cavity. This was just a little bit of a bulge into the onto the dura. The dura was intact and no involvement. So, yeah. How are you going to manage this? What are you going to? Are you doing steroids or sinus rinses or
Surgery.
surgery? Yeah. Okay. And what would you do? Open it up from below?
No.
Well, that's what we did. Open it up from below. relatively straightforward. The thing you find with these is the mucosal lining is always a little bit thicker than you initially anticipate, and you're kind of pushing it away and it sort of moves superiorly. But once you get into it, the diagnosis is clearly pretty obvious. And the thing you want to do is to make as wide an access into that as you can so that it doesn't recur. So, Hesham, I think we've worked our panel hard. We've given them a selection of cases. I think they've done very well on limited information. So I'd just like the audience to put their hands together and thank our panel. And thank you all for attending.